They always say this is a flight to so-and-so to make sure that you know that you're on the right airplane going to the right place. Well, I'm going to announce to you that you are now at the Healthcare Policy Center's panel discussion, Getting the Best for Texas in Health Insurance. So good, nobody's getting up and leaving. Welcome, thank you for being here. Thank you for your interest in this subject. Over the past decade, the rising cost of health insurance premiums has prompted a wide range of responses and reform efforts from lawmakers, the medical community, private health insurance companies, and employers. These efforts have been as diverse as the emergence of health savings accounts, the establishment of Obamacare Health Insurance Exchange in Utah, or pre-Obamacare Health Insurance Exchange in Utah, to the implementation of a single-payer system in Vermont. With the passage of Obamacare, the health insurance question has taken on a new dimension. It is more important than ever to find ways of controlling the cost of premiums and mitigating the negative effects of the law. So we're not going to be talking in this panel about how to change Obamacare. What we're going to be talking about is how to live within the Obamacare mandates. We've already seen premiums rise significantly since the passage of Obamacare, and industry leaders like Aetna's CEO are now warning that some policyholders will experience premium rate shock, with rate increases up to 100%, and that's not in 5 years, that's in 2014. State lawmakers are also facing an important choice of whether or not to create state-based health insurance exchanges according to the Obamacare law. Although presented by the administration as a way for people to, quote, shop for private health insurance, the exchanges are in fact nothing more than a vehicle for the distribution of standardized health insurance products and federal subsidies, and a mechanism to enforce federal regulations. Other provisions of the law, such as community rating and guaranteed issue, will take effect regardless of whether the states choose to establish exchanges or allow the federal government to do so. Because of this and many other restrictions the law places on health insurance plans, in addition to the long-term cost and running an exchange, TPPF's position is that the states should not set up an exchange and instead allow the feds to implement their own policies. Whatever flexibility the law affords is merely cosmetic. In addition, there are credible legal challenges to the exchanges. Whether the law allows federal subsidies and penalties to be administered through federal exchanges instead of state-based, state-created exchanges is a subject of a lawsuit brought against HHS by the state of Oklahoma, in which we think that will likely end up in the Supreme Court. In this context, the question of health insurance reform is something of a moving target, as we have been in a moving target since the passage of Obamacare. We have therefore asked each of our panelists to address one aspect or approach to health insurance reform covering a broad spectrum and differing viewpoints, from consumer-driven health savings accounts to government-run single-payer system. I'm going to introduce all of our panelists right now so that they can just come up following one another. Our first panelist is Dr. John Goodman. He is the president and CEO of the National Center for Policy Analysis and author of the new book, Priceless, which we're going to be having a book selling. We got all that worked out, didn't we, Dr. Goodman? Okay, good. Priceless, Curing the Healthcare Crisis. Dr. Goodman is widely known as the father of health savings accounts, and Modern Healthcare named him as one of 4 people who have most influenced the modern healthcare system. Dr. Goodman is also the Kelly Wright Fellow in Healthcare. The mission of the Wright Fellowship is to promote a more patient-centered, consumer-driven healthcare system. He frequently testifies before Congress on healthcare reform and retirement topics and is the author of more than 50 published studies and 10 books. Joel Allenbaugh is Chief Executive Officer of National Worksite Benefits Group. Incorporated. Joel co-founded NWBG in 2003, a full-service employee benefits insurance agency specializing in consumer-driven health plan strategies. Mr. Allenbaugh serves as the director of the Center for Health Reform Initiatives at the Maine Heritage Policy Center, one of our sister think tanks. And he is a licensed life and health insurance consultant and continuing education instructor. Mr. Allenbaugh is also the host of Inside Maine Healthcare, a television program airing on Time Warner Cable Network. And our last presenter will be Representative Michael Fisher, who has served in the Vermont House for the past 12 years. He has been Vice Chair of the House Human Services Committee, Co-Chair of the Mental Health Oversight Committee, and is currently the Chair of the House Health Care Committee. Representative Fisher was part of the leadership team that guided Vermont's universal health care law through the legislative process. His work toward health care reform includes a focus on public education at town hall meetings held across the state to respond to Vermonters' questions and concerns about the state's new health care system. And Representative Fisher left his legislature after having, they were sworn in yesterday, but his speaker gave him the okay to come to Texas and talk to us about what they're doing in Vermont. So he's missing his session, and we appreciate that sacrifice very much, Representative Fisher. So at this time, John?
Arlene, thank you for that very, very kind introduction. I thought our office was being a little bit generous when we suggested some of those remarks, but I enjoyed hearing every word of it. If you Google the John Goodman Health Policy blog, you're going to discover two things. First of all, it's about the only health policy blog on the internet that approaches health issues from an economic point of view. At our blog, we believe that the reason we're having all the problems we're having in healthcare is people face perverse economic incentives. And when they act on those incentives, they make costs higher, quality lower, and access more difficult than it otherwise would have been. And we're not going to solve these problems unless we get the economic incentives right. The other thing you're going to discover is that our health policy blog is about the only, in fact, it is the only blog, health policy blog of any political persuasion that has a sense of humor. I don't know what it is about the field that I'm in, but it tends to be dominated by a bunch of sourpusses. And not only do they not have a sense of humor, they often don't even know when I'm joking. It's gotten me in trouble more than once. And so for people like Paul Krugman at the New York Times, who has no sense of humor at all, we created these little humor alerts, you know, for the Humor Challenge. It's like a Yale sign, satire alert, so it means don't take everything entirely seriously that you're reading. We feel like if we don't make you smile once a day at the blog, we're not really doing our job. And so we'll do things like we had this one post on how Obamacare is going to push you into HMOs, they're going to ration your care. And then underneath that one, we had Aretha Franklin singing Say a Little Prayer for You. And then we had another post on end-of-life care, and underneath that, from YouTube, Bob Dylan singing Knocking on Heaven's Door. And then we had this really terrific exchange with the insurance guys and the doctors, and it went on for 50 or 60 comments. And finally, this one doctor got so frustrated, he said, your insurance guys are killing our patients. And I thought that was kind of interesting, so I reposted that and invited other people to comment. But underneath it, we had Leslie Gore singing, You'd Cry Too If It Happened to You. Sometimes we're accused of being irreverent, and I guess the worst thing we ever did, about 2 years ago, a man walked into the Parkland Hospital emergency room in Dallas, and he waited 19 hours and died before he ever saw a doctor. And I see some of you know about that story. We thought it was a terrible thing to happen, and we also thought it could happen in other cities, so we did have a comment on it. But underneath it, we had Lionel Richie singing All Night Long. What were we thinking? If you like our health alerts, I send out a health alert twice a week, and if you're really interested in health policy, you need to get the health alerts, and you also need to know about the blog, and the alerts will bring you back to the blog. Also, if health policy is something you're really interested in, you need to get the book Priceless. And so after we're through here, go up to the 6th floor and I'll sign a copy for you. But I think you're going to find that there's nothing else like it, and it's something that will help you a lot. Now, when I talk, I usually have my cell phone with me because you never know, even in the middle of a talk, you could have an emergency, right? That wasn't serious. The reason I have a cell phone is to tell you all something really interesting. There are more cell phones in the United States than there are people. Do you know that? If something goes wrong with my cell phone in Dallas, Texas, I can, in a matter of minutes, find a repair shop and with very little waiting whatsoever, get my phone repaired. There are even agencies that will send someone to my home, to my condo, to repair the home where I live, the phone where I live. There's a chain called iHospital, and the phone repair folks are called iDoctors. But over in the healthcare sphere, things are very different. The average wait to see a new doctor in the United States is now 2 weeks. In Boston, where we're told they have universal coverage, the average wait for a patient to see a new doctor is 2 months. Amazingly, 1 out of every 5 people who enters an emergency room in the United States today leaves without ever seeing a doctor just because they get tired of waiting. The mistake we've made in the United States is we bought into the same idea that has been dominant in every other developed country, and that is that no one should ever have to choose between money and health care. That the ideal healthcare system is one in which healthcare is free at the point of delivery. And it's a big myth that our system is radically different from Canada. It isn't. Primarily in the United States, we pay with time and not money, just as they do in Canada, just as they do in Britain, just as they do all over Europe. And the thing we have forgotten in all of this is that if you don't pay with money, you're going to pay in some other way. If you don't have markets for health care, you're going to find non-market barriers to health care. And what do I mean by non-market barriers? I mean, how long does it take you on the telephone to make an appointment to see a doctor? How many days do you have to wait before you get in to see that doctor? How long does it take you to get from where you are, your home, your office, to the doctor's office? And once you get there, how long do you have to wait before you see the doctor? I think it's really interesting that for all the other professionals, for the lawyers, for the accountants, for the engineers, for the architects, that exterior area in the office is called a reception area. It's only at the doctor's office that we call it a waiting room, right? Now so happens that there's a lot of evidence for this, that these non-market barriers to care that I just described are more important than the fee the doctor charges. And that's true not just for the middle class, it's also true for people who are poor. In the United States right now, there are about 50 million people who are on food stamps. And they can walk into any supermarket you and I can walk into. They can buy just about anything we buy. They pay the same price that we pay. They get to the checkout stand. They put the food stamps down. They put money on top of it. And you never hear it said in the United States that there are supermarkets that are not taking any new food stamp customers, right? Now, the only problem poor people have with supermarkets is they may have to get on a bus in order to get to one. But once they get there, there is no problem of access to food for low-income folks. Now, we have another 50 million people in the United States who are on Medicaid, and then most of them are the same people who are on the food stamp program. And what's the biggest problem people have on Medicaid? It's finding a doctor who will see them, right? I was in Boston not so long ago, and I struck up a conversation with a cab driver, it was a woman, and I asked her how health care was working in Massachusetts these days, and she was on Mass Health, which is her Medicaid program. And she said, well, I guess it's okay, but I'm having a real hard time finding a doctor who will see me. And I said, oh, really? She says, yeah, I had to go down a list of 20 names before I found one who would take me. And I said, were you going down the yellow pages? And she says, no, I was going down the list that Mass Health gave me. That's what they call universal care in Massachusetts. Meanwhile, we have in the United States 1,200, 1,300 walk-in clinics and CVS pharmacy. They're called minute clinics. They're called minute clinics to communicate to you that they know your time is valuable as well as your money. In Dallas, Texas, the cost for sore throat or an earache, all these costs are posted, by the way, so you know what you're going to pay, is about $75. But Medicaid, the Medicaid rate in Dallas is only half that, so the minute clinics are not taking any Medicaid patients, and I think you'll find the same thing is true in Austin, Houston, and really all over the country. We could greatly expand access to health care for low-income folks just almost overnight if Medicaid would only pay the market price for primary care delivered in these walk-in clinics. You have right here in Austin urgent care clinics. For a normal visit, the cost would be less than $200 for exactly the same care. Over at the hospital emergency room, it's $1,200. Medicaid, however, doesn't pay the market price, so your urgent care clinics are not taking the Medicaid clinics, so they're going to the emergency room, and it's costing taxpayers a lot more than it would. So if we just liberated the patients, allowed them, wherever we see a market working, wherever we think there's a market price, let Medicaid pay that market price. And not only would we greatly expand access to care, we would lower the cost to the taxpayer at the same time. And once we tell the Medicaid patients that they can have access to this kind of care, all of a sudden the minute clinics and the urgent care clinics are going to start locating in different parts of Austin and different parts of Dallas and Houston, and we're going to find that we can have a real market for primary care for low-income people. Whereas right now, they're in the other part of town. So the first thing we need to do is liberate the patient, and it has nothing really to do with Obamacare. Texas needs to take control of this, and it's something easy for us to do. The second thing we need to do is create personal and portable health insurance for small businesses, and large businesses too, if they want them. I find it remarkable that in Texas, like most other states, it is illegal for an employer to buy for employees the kind of insurance they most want and need. What is that? It's insurance that they own and can take with them to the next job, from job to job and in and out of the labor market. And not only have we outlawed that in Texas, but we're one of the worst states. Most states are don't ask, don't tell. But in Texas, insurance agents can tell me if I'm wrong. In Texas, do you not have an affirmative responsibility to make sure when someone's buying an individual policy that that money didn't come from an employer? Is that right? So we're worse. And we need to turn all this around. It should be the opposite. We should be encouraging employers to buy for their employees individually owned insurance, which they can take with them. We ought to actually think through how you make this transition, where employers can become defined contribution employers. You come to work for me, I tell you what your salary is going to be. I also tell you how much money is available to you every month for your insurance. So it's like a 401k plan. And then you bring insurance with you, or you choose a new plan, and the employer puts up a certain amount of money. And that's not that hard to do. And we would solve almost 90% of all the problems of pre-existing conditions if people had portable insurance. Almost all those problems occur because someone's leaving a group plan going to the individual market. And then the third thing we need to do is something that's really not talked about almost anywhere outside the National Center for Policy Analysis and my blog. And that is, we need to get health insurance looking like other forms of insurance. And by that I mean, we need for health insurance to be we need change in health status insurance in addition to the kind of health insurance you have right now. And what I mean by that is this, that if I have life insurance and I get a prostate cancer test and the results are bad for me, all of a sudden I'm a higher risk. But even though I'm a higher risk, the life insurer doesn't cancel my policy. I don't pay a higher premium. I continue to pay the same premium, stay in the same plan, and if the cancer kills me, then my family gets the proceeds of the insurance policy. In healthcare, it ought to work the same way. Now in healthcare, because it's employer-based, we're going to be moving from plan to plan more often than you would see in life insurance, but the principle should be the same. If I'm insured by Blue Cross and I have the prostate cancer test, now I'm a higher risk, I've got to move, I'm going to go over to an Aetna plan, my premium shouldn't go up. It's Blue Cross should pay the extra premium to Aetna that reflects the increased risk I now bring to the Aetna plan. That's the exact opposite from where everybody wants to go in health insurance these days. Everybody wants the sick person to pay the same premium as the healthy person. And if that's the way you want to regulate markets, then no one's going to want the sick person. Everybody's going to run from them. But if the sick person enters plans at a price which reflects the true cost of care, then you'll create a market to solve the problems of sick people. Then plans will begin to specialize in cancer care and heart care and other chronic diseases, which is what you want. You want to unleash the entrepreneurs. You want to encourage them and make it profitable for them to solve our problems instead of running from people who are sick. If you insist, as Obamacare insists, that insurers charge the same premium to everyone regardless of health status, then I guarantee you the insurers will try to attract the healthy and avoid the sick. There's no way that is not going to happen. That's what happens right now for federal employees when they move from plan to plan. But the bad incentives don't stop at the point of enrollment. They keep on coming. So once you've got people enrolled, the health plan's incentives are to over-provide to the healthy. Why? Because you want to keep the ones you have and attract more of them. You're making a profit on them. Under-provide to the sick. Why? Because you didn't want the ones you got. You certainly don't want to attract any more of them. That's not the kind of incentives you want to give health plans. You don't want to give them incentive to treat you poorly when you've got a real problem. You want it to be the other way around. You want, if you have a real problem, for all the plans to want you in their plan and to think of ways to provide you with low-cost, high-quality care. So those are three ideas. You may consider them somewhat radical. They're all doable, and come up to the 6th floor and get a copy of Priceless, and you'll learn more about all of this today. Thank you.
If you could talk to the people in my office, they would tell you that the stuff I'm about to talk to, I'm reasonably knowledgeable about. My ability to handle technology is might be my Achilles heel, so we'll see. It's probably fitting that I'm going next because I'm actually an insurance broker by trade, which you heard in my introduction. I actually started working in the policy field, well, really because I was working with clients and businesses trying to handle health insurance, and kept becoming apparent to me that every time a decision was made at the legislature, whether it was in Augusta, Maine, or whether it was in Washington, D.C., so in some way, shape, or form, it was impacting my clients. And we wanted to be a little bit more proactive, and that's sort of how I stepped into the policy arena. But from a very practical standpoint, the things that we deal with them as they translate on the street, if you will. Dr. Goodman was just talking about the sort of transition to get people more to individual policies, and what you need in order for that to happen is a healthy individual market. And I'm going to just sort of talk to you a little bit about Maine's market and what we've done to try to improve that, because I've spent years working with people to get them out of individual policies and into group policies. Not because I didn't want portability or some of the features that were just discussed, but because our individual market was caustic. And I think caustic is the right word. But what's interesting is how our market got that way. And it got that way because of exactly what you just heard. We in Maine did something many years ago that Obamacare is doing right now for the nation as a whole. We passed guarantee issue and community rating in the early 90s. And it had detrimental effects on our markets. And in fact, if you read the Supreme Court decision, I know there's a lot of policy folks in the room, so there may actually be some who actually have read the Supreme Court decision on the individual mandate. I would tell you to take special attention to Justice Ginsburg's comments, so that you have sort of the major decision, then you have the dissenting or concurring opinions, and I've not yet been able to really determine if Justice Ginsburg's comments are a dissenting or a concurring opinion, because she's sort of got both in there. But one of the things that she says is she's defending the concept of we need everyone to be covered in the pool, if you will. If we don't, and we pass guarantee issue and community rating nationwide, like states like Maine did, and literally in her comments she says the results will be disastrous. And I just wanted to explain that that's exactly what happened to us. So what you're looking at, that when we I should mention this too, when Obamacare passed, I believe there were 4 states in the country whose regulations at the state level were already more restrictive, not less restrictive, than what the federal law does, us being one of them. And we had an interesting dynamic in our state because for the first time in over 60 years, so just a little bit more than my lifetime, we had a Republican governor, Republican House, Republican Senate. It's the first time that had happened in a very, very long time. So we had somewhat of a different mindset, I guess, than the folks who originally passed our guarantee issue and community rating laws. And so we sort of leveraged Obamacare to move right. I don't know that folks down in Washington would be happy to hear that, but that's exactly what we did. And what we did was we tried to use the flexibility that it gave us to create a healthier market, especially in our individual market. Well, as this was going on, we were debating this in the legislature, and we passed a law called Public Law 90 that did a lot of these things. We had some information. I'm actually bringing you, showing you a couple of slides that we used for the legislature in making some of these points. This was provided to us in our state. Anthem bought our Blue Cross affiliate. So in Maine, in the individual market, that pretty much is our individual market. It's Anthem. In the early 90s, there were about 11 or so companies that competed for individuals in the individual insurance market. We passed guarantee issue community rating, and you can just sort of watch the floodgates. Everyone else said, okay, great, and left the market. Last man standing was Blue Cross, got into some pretty tough financial shape. Anthem swooped in, bottom up. So we essentially have a single carrier market in our individual market. So when you see these slides up here and you'll see that it says Maine versus New Hampshire and it talks about Anthem, that's pretty much representative of our individual market. And what this shows you, what we did, you just heard the concept of making everyone pay the same rate, right? Whether I'm healthy, whether I'm sick, that's true community rating. We didn't quite go that far, but we got awfully close. We had a 1.5 to 1 rating band flexibility under Maine law. So essentially, if you wanted to talk to an actuary and say, okay, take the 20-year-old, take the 60-year-old, what's the cost difference going to be? Well, on average, that 60-year-old is going to consume about 5 times as much health care as the 20-year-old. So an actuary would say, if I'm going to charge the 20-year-old $100, I want to charge the 60-year-old $500 for the same policy. Well, Maine said you cannot charge more than 1.5. So if you're going to charge $100 for the young person, you got to charge only as much as $150. And you know, in theory, it makes some sense. You say, okay, well, we don't want the 60-year-old to pay the 60-year-old rate, so we really want them to pay the 40-year-old rate. So if the 20-year-old rate also pays the 40-year-old rate, that'll work. But there's something called economic incentives and free will. And what happened, of course, was those 20-year-olds said, well, okay, well, I don't really want to pay the 40-year-old rate. I'm feeling pretty invincible. I think I'll take my chances. And so I'm just going to show you a couple of examples of the impacts. What this is showing you, we took an individual policy in Maine, happened to have a $5,000 deductible. And I don't know if $5,000 sounds high to you. A few years ago, the Bureau of Insurance in Maine did an analysis on this, and the average individual deductible sold in Maine had a $7,000 deductible. That compared to $1,500 nationally. So just to give you an idea of what's happened to our rates in the last 20 years since we passed these reforms. So what this is showing you is, did it happen? So are we all paying the 40-year-old rate? Well, as you look at this, we're comparing Maine and New Hampshire. I mean, we have, Maine, that we only share our border with one state. It's New Hampshire. And what you're seeing is, red is the premiums for Maine, green is the premiums for New Hampshire. Same policy. And so what you're seeing on the very far end is that a 60-year-old pays about the same in Maine as they would in New Hampshire. What you're also seeing is that a 20-year-old pays about 3 times as much in Maine as they would in New Hampshire. So the real question is, what happens? And this is the answer, or this is the answer to that question. And if you'll notice, at the time when we ran this, I'm going to just kind of focus on the left side of that chart, that green bar that says 1727. We have similar populations between Maine and New Hampshire as well. In the 18 to 24 bracket, they had 1,727 individual policyholders in New Hampshire. In Maine, we had 163. So in the early 90s, we had about 100,000 people covered in Maine's individual market. Today, we are pushing to have 30,000 covered in Maine's individual market. And that's why I say we have had people moving from the individual market to the group market. In many cases, we've had people just flat out going without, which, again, 20 years old. If I tell you, hey, I think if you saw that last chart, you know, $350 a month, you can have this $5,000 deductible policy, and you're making who knows what, you know, it's not a tough decision. So I just would mention that those economic forces also translate to individuals making decisions with free will. And you might say, well, Obamacare is going to solve that because, as Justice Ginsburg said, the problem was there was no mandate for people to buy coverage. So if we tell those 20-year-olds you have to jump in the pool, then we should see those rates go down for everybody. Well, I think that's true. My question for you that I would pose is, if you're that 20-year-old, and I tell you, okay, you're going to pay, let's call it $3,000, $4,000 a year in premium for a policy that meets the minimum acceptable guidelines. I think I'm being generous with the premium here. Or, young man, you will pay a penalty, and it's going to be initially $95 a year. What do you think that you're going to do? And by the way, in the Supreme Court decision, something else, you know, you might say, well, okay, well then we'll just keep raising that penalty until we find that sweet spot. You know, where is the amount of the penalty sufficient enough to get to the end result, which is for those folks to buy policies? Well, in the Supreme Court decision, they actually spoke to that issue and said the reason that they thought that the tax was appropriate, and I say tax because that's an important term, for the individual mandate was because it wasn't so significant. But if that, and they didn't really define, well, what's too much? But just like with Medicaid, they said, okay, if you don't expand Medicaid, we're going to pull all of your funding. That was too much. It was considered coercive because it's such a big piece of state budgets. Well, they looked at the individual mandate and said, well, yeah, but a $95 fine, I mean, it's not so significant that it's that big of a hardship, so this is okay. But if that number got big enough, at some point, you'd run into the same issue. So there is a problem with sort of getting to that point, I guess. So real quickly, because I got my 2-minute warning, what we did in Maine, we went from 1.5 to 1 in our individual market to 3 to 1 for starters. We wanted, and that's the limits under the Affordable Care. We wanted more ability to vary those rates. What we also did is we set up a reinsurance program. So, which essentially puts an assessment on all payers in our state, all of us with group coverage. We pay $4 per member per month. That goes into this reinsurance pool to help cover the cost of the sickest in our individual market, which is essentially what our individual market has resulted in is, you know, as rates go up, the healthy ones drop, the sick ones stay. And we have some issues with our reinsurance pool, which I'll get to, but I just want to tell you that the first thing that happens, our reinsurance pool is a little bit different in that when an individual goes and applies for coverage, it's prospective, so they're going to answer some health questions. They're going to be seated to the pool based on those questions or not, but the policy that they purchase is no different whether they were seated to that pool or not, nor are the premiums any different. So they get coverage just like anybody else. Our challenge is that the ACA tells us that that reinsurance pool has to be retrospective. And so they're not saying that they'll approve our pool. But I just want to tell you what happened. And I'll close with this. In July, the reinsurance pool took effect in July, and I serve on the board for the reinsurance pool to give you some perspective on this. In July, it actually took effect. We had a 1.7% rate increase approved for the individual policies with Anthem for July of 2012. That was the lowest rate increase we've seen in the individual market literally in decades. They've averaged about 20% prior to that. And that was the average, so there were a lot of folks who saw their rates go down. And that was to keep the same policy. The other thing that happened is Anthem introduced a suite of new products. There's a 2 missing in that second up to 60%, with rates that were literally up to 60% less expensive. They were slightly different products. They had a closed book and an open book, and they put some new products on the table. They also introduced a new HSA product in the individual market, which was the first HSA product in our individual market in years. Now, I've been going to these insurance companies for a long time and saying, hey, we need new products, we need an HSA in the individual market. market, and what they told me was, we are not investing a penny in a dysfunctional market. So when you get a market that works, there are other things that happen as a result, and one of those is the carriers are willing to make the investment to put the products on the table. I also said we have Anthem. They're sort of the lone soldier left holding the bag in Maine with the individual market. Well, we now have a couple of other carriers that are actively looking at putting new products in the market. So this was a 1.7% average increase. This was up to 60% less expensive products on the table, and by the way, less expensive for people in every single age bracket, not just the young. Up to 30% less expensive for someone between 60 and 64. And this is without a single competitive pressure, which we think will follow. And I think that's my time. Thank you.
Let's see if I can get us out of here. Hi, thank you so much for having me. My name is Mike Fisher, as I was introduced, chair of the House Healthcare Committee in Vermont. And I've been in the legislature for this 13 years. Thank you for the opportunity to miss all the pomp and circumstance that's happening in my state. I've been through it a few times. I didn't get to hear my governor give his address today, his opening address. Instead, I got to hear Rick Perry. I think it'll be a little bit different. I did not accomplish this, did I? Yes, here we are. So just a word or two more about who I am and where I come from and how you find yourselves. It's sort of I haven't heard anybody say this at this conference yet. I am a Democrat. Not only am I a Democrat, I am on the left side of what it is to be a Democrat, even in Vermont. So when I told the director of healthcare reform I was coming to Texas to talk about single-payer healthcare, she said, "I'm worried for your safety." But I enjoy a challenge, and it's good to be here. When I'm not being a legislator, I am a social worker. I spend my days visiting with low-income rural families with young children, teenage parents in a rural part of Vermont. And I spend my time sitting on their couches, sitting at their kitchen tables, hearing about what's going on in their lives, and partnering with them to help them do the best job they can in being the best parents they can. And often, that's about accessing services, accessing healthcare services. And many of these folks are on Medicaid. I'm very familiar with the challenges that Medicaid recipients have, but I also am really familiar with innumerable success stories of government partnering through a private nonprofit, but partnering with families to do the best job they can. And you know what? People want to do the best job they can. And with a little bit of partnership, a lot of people do a lot better. I've seen it firsthand and am in awe of how well people do, even when there's tremendous challenges. So I come to this discussion about healthcare, again, from a very different place. When we talk about actuarial levels and medical loss ratios and reinsurance and HSAs, and we start to throw all these terms around, we often forget that we're talking about families who have a premature baby and a tremendous bill coming at them, or who have experienced or have a chronic illness like diabetes or high blood pressure or depression. And I'm pretty familiar with, we should all be pretty familiar with what the costs are of not providing the care that people need. And sort of a no-brainer statement, it's sort of so simple, it seems stupid, but just because you don't pay for people's care doesn't mean that their illness goes away. Often it means that their illness gets more acute, more difficult to treat, more expensive to treat, and there's worse outcomes in the long run. So I'm often, a big piece of what drives me is a concept of right care at the right time. We do very poorly on that in our current healthcare system, and we can do a lot better. So, all right. I'm going to start my presentation, time will be up, right? So there are 4 principles that guide our approach to healthcare reform. And just very quickly, costs, access, improved outcomes, and pay for it in a fairer way. And we are challenging ourselves to measure every step forward in healthcare reform against these principles. And I'll spend just a few minutes on costs. Our current system costs too much, and we don't get great outcomes for it. And the rate of growth, I know the Vermont numbers, I don't know the Texas numbers, I apologize. I spent a minute or two looking for it on my phone, which is not very smart. And, but in Vermont, there's 600,000 Vermonters, 620,000 Vermonters. We're tiny. And we spend $3.5 billion a year on healthcare. And the rate of growth is 7.1%. It's a tremendous expense, and it's growing at an unsustainable rate. And so one of the primary answers to the question of why are we going in the direction we're going, moving towards a more simple, unified system, I believe we have no choice. I believe that if we don't accomplish real savings in healthcare, then it will just become more and more expensive, and fewer people will have access to it. Now, when you say to somebody, when somebody says they're trying to achieve savings in healthcare, you have to be careful, because often what they really mean is they want to shift their expense to somebody else. If you look at any segment of the healthcare system, let's say you're a business person and you say, I want to have savings in my healthcare expenses. Well, what tool does a business person have? Often it is to shift the expense onto employees. If you're a state legislator and you say, I want to save money in the state budget on healthcare, what tools do you have? Well, you can do the same thing as a business person for your state employees. You can shift the expense onto the state employees. Or you can shift it onto the general population by underpaying providers. We do a lot of that in this country. We do a lot of that in Vermont. I would argue that it is a hidden tax. Again, I apologize, I know the Vermont numbers. We spend the Medicaid cost shift, the hospitals tell us, and I always got to question what hospitals tell me, but hospitals tell us that, that the Medicaid cost shift is about $100 million. So we're underpaying providers. Providers are charging other people more, and I think that's a tax. I think it's a hidden tax. I don't think it's fair, and I think it's something we ought to be able to do away with. If you're trying to save money and you're a hospital administrator, well, then things really truly do get perverse, because, well, there's things you can do with your budget, of course. It's a big, complicated thing, but generally, you want to increase your procedures that bring in more revenue and decrease the procedures that you do that you lose on, like maybe on maternity, or maybe on mental health. Maybe psychiatric care is a loss, is something that hospitals lose money on. So a hospital, in order to save money, is going to do actually the opposite of what we might want to do if we were looking at a system-wide approach. They're going to increase procedures that they bring more money in on. And who can blame them? Of course, that's what they have to do in order to make their budgets work. And we need providers to be viable. So I have no criticism of providers for doing exactly that. That's what they have to do to survive in the system, and I think we can create a system that has incentives to go in other directions. Okay. So it's very generous of the introduction for saying that we have achieved single payer. We are far from it. It is much more aspirational. But we see the Affordable Care Act. By the way, that is what it's called. I like to call it Obamacare too, but that's because I support it. We see Obamacare as a stepping stone forward in how to achieve a much more of a system-like approach, a unified system. And so we have built an exchange, which will go into effect next year, January of 2014, where everybody in the small and individual group marketplace will be inside the exchange. We'll have no outside the exchange marketplace. And where the premium tax credits and cost-sharing subsidies provided by the federal government will go a long way in terms of helping people be able to afford the care that they need. And when a waiver from the exchange is available to us, current law is that the feds can't give us a waiver until 2017. Our state law requires the administration to seek a waiver from the exchange so that we can move beyond insurance products towards a self-insurance product for the entire state. So I think I may skip a little bit of this, but well, one of the things we discovered when we looked carefully at our healthcare system was that there was no system, that there was nobody in charge, that there were maybe too many people who thought they were in charge, and that it led to a lot of craziness. And so we created a board, we call it our Green Mountain Care Board, who is tasked with defining a number of the directions moving forward for healthcare reform. So ultimately, Green Mountain Care will be defined a lot by this board. So we're trying to move to a place where people get coverage because they're Vermonters, because of they're a resident of Vermont, and where everybody has to pay in because based on their ability to pay. Healthcare is not free. It will never be free. It will always be expensive. But I believe that we can do a lot better job of figuring out how to raise the revenues for it in a thoughtful way instead of the haphazard way we do it today. Another important thing is that we have to figure out ways to reform, we have to reform our our payment system in such a way that drives a new delivery system. And let me speak for a moment about a project we've been working on called Blueprint for Health in Vermont. It's called Blueprint for Health. It's a medical home model. About half Vermonters are now in Blueprint practices. And it's sort of, from a social worker's perspective, it's a no-brainer. One-stop shopping where people can get the care that they need. Today, if somebody goes into their primary care physician and says, and implies that they may have issues with depression, often, or drug addiction, often the provider doesn't want to ask questions about it because they don't know what to do about it. And if we put mental health professionals in the same office with the doctors, if we put behavioral health professionals, there's a difference between mental health and behavioral health, which I'd be happy to talk about more, but helping people achieve the behaviors that they need in order to have better health outcomes, we have better outcomes along the way. And so when we tried to get all of our insurance carriers to practice, to be a part of the Blueprint for Health, to comply with the law, we had a range of experiences. We had our Blue Cross, now they're created by statute and a little bit more easily defined by the legislature. They said, yes, of course we'll participate. We have a regional carrier called MVP, which is based in New York, and they hemmed and hawed and said no, and then they ultimately said yes, but it took a couple of years to get them to participate. Cigna said no, we won't participate. We don't want to be a part of it. We don't see its value. And ultimately, we had to pass a law saying that they have to. When you're trying to align practices with multiple payers, it's a tremendous challenge. It's a very hard thing to get the payers to participate in these kind of projects. And so ultimately, I believe that when we're aligned into a single payer system or a unified system, we'll be able to be much more effective at creating payment structures that will drive different practices in the delivery of care. Ultimately, coming all the way back around to what I said at the beginning, right care at the right time leads to better outcomes. And often our providers are not, while they have great values and people go into medicine for the right reasons and they want to help get people better, often the systems that they are a part of don't have the same incentives. My time is up, but I just got to tell you one quick, quick story that illustrates that last statement I made. And that's that I was at a hospital board meeting, and this is a number of years ago. And the CEO was talking to the board before talking to a group of legislators. And the CEO said, our budget doesn't look good today, but rest assured, we're coming into flu season. So we'll be okay by the end of the year. Again, who can blame providers for practicing the way they have to practice to make it work in this system? But imagine, if you will, a world where the provider could say, I'm invested in the people in my catchment area not getting the flu, and I could even save money by being out there and preventing more people from getting the flu. Flu is probably a bad example of that today. I think we do a much better job. But imagine if it was diabetes. Thank you.
Now it's your turn. We've thrown some ideas out there. We're ready for your questions and to be directed to our panel. Yes.
This is for John Goodman. John, your institution started the whole concept of medical savings accounts, and it got a lot of attraction. In fact, many people I talk to who have medical savings accounts are very, very for them. How did we lose the traction? What happened, John?
We haven't lost any traction. There are 27 million Americans who have either a health savings account or a health reimbursement arrangement, which is a variation on that. So 27 million Americans have those accounts, and they are the fastest growing product in the health insurance marketplace. Am I right? Okay. Am I right? Okay. The insurance guys confirm that. Plus, here's something interesting. All of you know what a flexible spending account is. This is a use it or lose it account, which we've never liked because it encourages people at the end of the year to waste money. Obama, his administration is about to, by executive order, by a rule change in the Treasury, going to let those accounts roll over. Apparently, there was never a law that said they couldn't roll over, but that's the way Treasury ruled, and Treasury created use it or lose it accounts. And when I tried to get the Bush administration to undo that, they thought, oh, that's too radical, we can't do it, Congress won't like it. But now Obama's about to do it, so that'll be 35 million more accounts that are savings accounts for health care. So this is where we're going, and I'll tell you something else surprising. A lot of people think that the way the Obamacare subsidies are going to work in the exchanges, that the health savings account plans will be the most popular plans of all. So they've been a success.
Did they reduce the limits on it, or the amount that you can contribute? I thought I read something.
No, they reduced the limits. They reduced what you can contribute to a flexible spending account, and that started this month. $2,500 is now the maximum.
Just to add to that too, John here, happened to be in DC last week, and the requirement for plans to meet an actuarial value, this measurement under the Affordable Care Act, the HSAs, as the calculator currently stands, basically all HSAs do fit within the actuarial value. So they're okay, I guess, if you will, in the insurance market. There are other pressures pushing against HSAs other than just the actuarial value, but for the time being.
What are those other pressures?
Ann?
What are those other pressures? Well, there are a couple. So one is with the small group market, we are under the statute for Obamacare. It basically says you can't have more than a $2,000 deductible. I don't know what the deductible levels are here for small businesses in Texas, but I can tell you there are not a lot of companies that have deductibles $2,000 or lower in the state of Maine. And they say that you can you can count contributions to HSAs and HRAs when you're figuring out the actuarial value, but I was meeting with an insurance carrier yesterday and saying, you know, if you can't offer more than a $2,000 deductible, but someone can use an HRA, HSA funding, are you going to have the products on the table for them? For example, will you have a $5,000 deductible policy with a requirement that they fund a certain 3,000 of that through these other vehicles? And the short answer was not encouraging. So I think there's a lot of questions about how the insurance companies will react to these regulations and what products are available on the street, not just what we all have to have on the street. And there's another issue with HSAs having to do not with the actuarial value, but with, thank you, the medical loss ratio. Those products by nature are going to have lower loss ratios than lower deductible policies, so that might put pressure on insurance companies in order to meet those requirements to offer plans that have lower deductibles.
Ann?
I was going to ask a real boring, wonky question on MLRs, but I think I'll step up and ask maybe a more fundamental question, starting with Dr. Goodman, who first raised the question. You talked about the problem with Medicaid not paying market prices. And one of the obvious, you don't have to be an economist or budget expert to think, well, if Medicaid pays better prices, then won't number one, the prices in Medicaid are 100% determined by our state legislatures. Every single state legislature sets its own rates. How do we get there? You know, won't that increase in year one the cost of the Medicaid budget? And how do you get legislatures, particularly, for example, one like ours here in Texas, to buy into your idea?
Okay, first of all, I never said Medicaid should pay better prices. That would, that would obviously increase costs to the taxpayer. What I said was that wherever we find a real market working, like the Minute clinics, like the urgent clinics here in Austin, so there's a price determined in a marketplace instead of dictated by third-party payers. Pay that price, and it's probably going to be a lot lower than what you're now paying. What's the alternative to the urgent care, the Minute clinic? It's the emergency room or doctor's office. Those are more costly alternatives. So that's the first step, and you would just immediately open up huge access to care for low-income people. Plus, I guarantee you the Minute clinics and the urgent clinics will start locating where poor people live if they can make a profit off of providing them with care. So you get higher quality care, lower costs. But since you brought it up, there are other things that we're doing wrong here in Texas. You don't, when you're shopping for groceries, you don't pay 2 or 3 times as much at one store as you do for the other store. You don't do both. You pick the lower priced store for the goods you're going to buy. We don't do that in Medicare or in Medicaid. And we have control of Medicaid. And so we ought to buy health care the way rational people buy anything else. And if we find one hospital that has high quality, low cost care, the other hospital costs twice as much, send the patients to the hospital where we get the better deal. In other words, selectively contract. And if we're willing to do that, and again, I'm not saying pay more, I'm saying buy smartly. And in doing things like that, we could cut the budget and provide higher quality care at the same time.
I have a question for Representative Fisher. Tell us how the insurance companies are going to function once you're at 2017 and you go to single payer. Will there be insurance companies in Vermont?
Ideally, is this on? No. The short answer is no. I think
that's why I said I didn't want to go along with it.
I think our Blue Cross is when they say to us that they want to partner with us in the reform effort in the long term and in the short term, it's clear to me that they are positioning themselves to attempt to become the administrator. But again, we are a small state. Creating a single self-insured pool is what we're after. And so the task of administering it will still need to be done, but it is something that ultimately one carrier could take on and become our contractor to do it.
And so a follow-up question to that is, if the already in law plan is to go to a single-payer system, and you have this 2014 health exchange, state-based health exchange. How many companies do you anticipate being willing to participate in your state-based exchange for a maximum of 3 years?
So the companies that are currently in our state have all indicated that they're interested in staying. It is a relatively small set of companies. It is our Blue Cross, as I mentioned before, our Blue Cross. Is MVP in Maine? No, MVP is in just a few neighboring states, as well as Cigna is in our marketplace. We don't anticipate new companies to come in, though the federal law does require there to be two multi-state plans, one for-profit and one nonprofit. And though it's clear to us that that won't be in place by 2014. And then further, in addition, there's another provision of Obamacare that allows for the creation of a cooperative of co-ops. And we have one new player on the block who is pulling together a co-op insurance product, and I anticipate them to be part of the marketplace. So the long and short of it is that we believe we'll have more providers, more carriers, starting in 2014 than we currently have.
Okay. Yes, sir.
For Representative Fisher,
Yes.
One of the problems with Texas Medicaid is that it doesn't require a copay of patients, which so everything is, quote, free, which tends to lead to overuse of health care. Well, what have you done in Vermont to limit overuse of emergency departments and increasing costs?
So our hands are somewhat tied by the feds in some of this, not surprisingly. It's interesting to be from a very liberal state complaining about federal control, joining with people from conservative states. But we have instituted copays, nominal copays, where we could, and increased them in places exactly like you just suggested, emergency room visits. There's also, there's some no-brainer approaches, things that we should be doing better at. How many people in your state visit the emergency room more than 25 times in a year? That's a known set of people who we're failing for one reason or another. Either they are really sick and not getting the care they need, or they don't understand when the right time is to visit the emergency room. Either way, I like to say this, I am a social worker. Social workers are cheap. And you save a lot of money by putting those folks on a caseload of people who need to help doing better management. Similarly, multiple rides in ambulances. There's a set of things that we could very easily label, things that we could do a better job of managing our Medicaid population.
Question for
Yes,
Ron,
Ken.
please. How are y'all doing with doctors looking forward?
Yeah, real problem. It's a real problem nationally. We don't have, if I could magically say tomorrow everybody was funded to get primary care, we would have a real serious crisis in there not being enough primary care physicians. It's a problem that exists in the current system, and it's not easy to make primary care physicians. They take a while to train up and get into place. And there are, as we was talking earlier, there are incentives for those folks who are in training to become doctors often don't choose primary care as a way to practice medicine. So it's a real challenge, and one of the things I didn't mention is that we believe that that there needs to be real investments in our healthcare system if we're going to be able to achieve universal coverage. And a key place there is in workforce.
Eric?
Representative Fisher, what are the roles, speaking as a follow-up to that question, the role of nurse practitioners and PAs then in your state, and also the regulatory burdens there in terms of the relationship between MDs and NPs and PAs on the practice level?
I was telling somebody else earlier that I took a turn being on a legislative committee that oversaw the Office of Professional Regulation. And it's an interesting world, either in the medical practice board side or in the rest of the world of Office of Professional Regulation. We define PAs as primary care physicians, and they're a key part of the delivery system. And though there are challenges, you know, exactly what you just said, the relationship between the supervising physician and the PA, we have continued to loosen that. For instance, does the supervising physician need to be on site at all times? When you live in a small, in a rural place, often you need to, we have become more and more flexible on some of those standards. I see them as keys. In answer to your question, key to success.
Dr. Good.
Yeah, I just want to say, since the question was brought up, we need to realize here in Texas that we're one of the worst states in the country on keeping nurses from delivering care that they're perfectly capable of delivering to patients. And we hassle the men in clinics, we hassle the nurses, we have ridiculous rules about how often the doctor has to meet with them and so forth. Some states like Oregon, a nurse can hang out a shingle and not be supervised by a doctor and do all the things nurses are capable of doing. And because we're a rural state, these rules I just described are worse than they would be in a state that's more urban.
And I'll just add that in addition, telemedicine is a growing field. This year we required our insurance carriers to reimburse for telemedicine, real-time, high-quality video interface medicine in the same way they do for face-to-face. Again, how do you get the right care? This is often specialist care that we're talking about to people where they are.
One last question. Jim?
This is a question also for Representative Fisher. You're popular at the session.
These are new ideas in Texas.
Exactly. I was wondering, I may have missed it in your presentation, you may have already said this, but would Medicare be folded into the statewide self-insured plan in 2017? And if not, which you may have the ambition to do so, but I would probably safely predict you would fail in doing so, just as a political matter. But let's assume you can't succeed. I want to know if you're trying, but if you can't succeed, in what sense is it really single payer? In what sense would you really have control over the delivery system?
So first off, let me back off from the word single payer. My governor uses it. It was a part of the presentation up there. I generally try not to use the term single payer because it's not honest. There will always be multiple payers. There will always be people on Medicare. There will always be federal employees, federal retirees from large corporations, ERISA plans, things beyond our jurisdiction to have any impact on. Medicare is, of course, a federal animal, and we would hope to integrate it where we can. People are fiercely defensive of horrible Medicare plans. It's something that's mystified me for a long time. People love their Medicare plans that are very expensive and don't provide very good care.
Medicare plan or Medicare?
Medicare. In large part, we believe that we can integrate some of the billing and claims process if the feds will allow us to, but I don't pretend to hope that the feds will allow us to fully integrate it. I would tend to see Medicare as something that we would wrap around.
Well, I think we're bumping up against the next panel. Before I let you go, I would like to introduce to you a new face at Texas Public Policy Foundation. John Davidson is our new health policy analyst, and so you will be hearing from him at the next panel. But now let's thank our panelists for a very interesting